whether you want to leave your video on or off. It's entirely at your discretion. Just to be aware in terms of connectivity, sometimes if you're struggling with that, it's often a good idea to switch off your video. That it just might allow the webinar to continue. In terms of issues with sound, first thing to check is that whatever device you're on, your computer, phone or otherwise, check your sound is muted or turned down. If you're still having issues with hearing us, the best thing we could say is come out of the Zoom meeting and go back in. Sometimes certainly at the start, if there's a lot of people coming in at once, people's sounds can be affected. And so you can go out and come back in again. We will try and fit a Q&A session in at the end. And the chat box is there for that. So if you have any questions, if there's anything you hear as the presentation goes along, just put it into the chat box. And I will flag those with Ruth and she will deal with those at the end. We may use some anonymized information from the webinar in the future. As I said, it is being recorded and it'll be put up with the other webinars on the IIOP website probably towards the end of the week if you want to go back and review if there's any material that you want to go over. So without further ado, our speaker tonight is Dr. Ruth Ceannt. She's a specialist reg in public health medicine. She's currently working with the NHPC, the National Health Protection Service. And prior to that, I suppose, going back a bit further, she would have started her career in psychiatry and then moved into public health. And she would have done a rotation with the National Immunisation Office, which I think would have coincided with COVID vaccines going out and being upscaled in that. So she has done some research in that area that you might talk to us about through the presentation. And I suppose as part of that, one of our key areas of interest is vaccines and vaccine hesitancy, which is what we're going to look at tonight. So I'm going to hand you over to Ruth now, who's going to share her slides and run through them. As I said, we aim for an hour, and if we've time at the end, if you have questions, I'll put them to Ruth. And enjoy the webinar. Thank you.
Great, thanks, Sinead. I'll just get through the screen sharing bit. That's always my stumbling block. Okay.
Yep, that's good, Ruth.
Okay, so you can all see that there?
Yep.
Yeah. Okay, great, thanks. So as Sinead said, my name is Dr. Ruth Ceannt. I'm a specialist registrar in public health medicine, and I'm working with the HPSC, which is part of the National Health Protection Service. And previously I was with the National Immunisation Office. I'm very pleased to be here with you tonight. So I will go ahead with my talk there. So just to start off with the objectives for tonight. So the objectives are to understand what vaccine hesitancy is, to understand why some people are vaccine hesitant and the different components of vaccine hesitancy, to take a closer look at COVID-19 vaccine hesitancy in parents of children under the age of 18. So I did a study a couple of years ago, which has looked at vaccine hesitancy in that group, and to gain insight into how to address vaccine hesitancy. So what is vaccine hesitancy? Well, the WHO defined vaccine hesitancy as a delay in the acceptance of vaccination or refusal of vaccination despite availability of vaccination services. It's complex and context specific, and it varies across time, place, and different vaccines. And it's influenced by several factors such as complacency, convenience, and confidence, which I'll talk about now in a minute. So it's dynamic. A person might accept one vaccine, but not another. So say they'd accept their flu vaccine, but they won't take a COVID vaccine. Or they might accept a vaccine at one time, but not at a different time. Say they might accept a COVID vaccine if they're going abroad, but not if they're staying at home or something like that. As I mentioned, it's complex, and the group of people who are vaccine hesitant do not form a heterogeneous group. They do not form a homogeneous group. They're quite a different group of people. They don't all have the same characteristics. A lot of different people can be vaccine hesitant. There are many factors at play, and there are many different reasons that a person can be vaccine hesitant. Sorry, I'm just trying to move something out of the way of my screen so I can see the slides here properly. So why is it important? The WHO identifies vaccine hesitancy as one of the top 10 global health threats. As vaccine hesitancy increases, vaccine uptake can obviously decrease. And this can then impact on the re-emergence of infectious diseases that have been kept at bay by vaccination and have been nearly almost forgotten, some kind of nearly close to elimination even. And this is a threat at an individual level and at a population level for herd immunity. Some vaccines require a very high level of uptake in order to maintain herd immunity, and some not as high. But to maintain effective control of the disease, usually quite a high uptake is required. So, for example, measles requires a 95% uptake, mumps is about 88%. Herd immunity is important then to protect those in the herd that cannot be vaccinated. So there's always a minority of people who can't be vaccinated for certain reasons with certain medical conditions. So any small uptick in vaccine hesitancy and therefore decrease in uptake can have effects on a population level. And this is why it is essential to maintain confidence in vaccines. I suppose the fact that some people are vaccine hesitant is probably a good sign that vaccines have worked so well that people no longer fear the diseases they protect against. And as I mentioned, they may have forgotten, they're so rare that people have forgotten their devastating effects, such as few enough people would remember iron lungs from polio back many decades ago. This, of course, though, creates its own problems. And as mentioned above, if hesitancy increases, the diseases that vaccines protect against will increase. This can currently be seen in real time with the re-emergence of certain diseases, such as recent measles outbreaks in various parts of the world. There's a measles outbreak in France at the moment, and the re-emergence of cases of polio in the Western world. There are some rather worrying findings contained in a report published earlier this year, I think it was in the late spring, by UNICEF, that confidence in vaccines is slipping globally. And the public perception of the importance of routine childhood vaccines for children declined during the COVID-19 pandemic. So I'm just talking about their routine vaccines, not COVID vaccines, in 52 out of 55 countries studied, including in Ireland. And in Ireland, the perception of the importance of childhood vaccination fell 6 percentage points from 91.5% to 85.5%. The biggest reduction in confidence was in people under the age of 35 and in males. And the ECDC, so the European Centre for Disease Control and Prevention, has recently warned about the potential for rising measles outbreaks in Europe, and I mentioned the one in France, and the re-emergence of polio. A recent paper from Japan demonstrates the potentially tragic effects of vaccine hesitancy. So to take the HPV vaccine against cervical cancer and other forms of cancer as an example, HPV vaccination began in 2010 in Japan for girls aged between 12 and 16. And initial coverage was very good. It was high at 70%. But this dropped down to 1% due to hesitancy related to now disproven concerns regarding the vaccine side effects. And the rates there have never fully recovered. This paper from Japan used modelling to estimate rates of cancer and deaths. And this is a quote from the paper. The vaccine crisis from 2013 to 2019 is predicted to result in an additional 24,600 to 27,300 cases and 5 to 5,700 deaths over the lifetime of cohorts born between 1994 and 2007, compared with if coverage had remained at around 70% of the HPV vaccine since 2013. So that's quite alarming and quite a real life effect of vaccine hesitancy. So why are some people vaccine hesitant? And I think I mentioned before that there's several factors. Complacency, convenience, and confidence are the 3 C's of vaccine hesitancy. So complacency means when people are not particularly worried about the risks or are not aware of the level of risk. They might perceive the risk to be low and they might be complacent about it, thinking things like, it won't affect me, sure, we live in a safe part of the world, or my children don't need a measles vaccine, there's no measles here, or for example, oh, there's no COVID around at the moment, or sure, COVID has gone away. And that attitude is there a little bit about COVID and also other sort of current vaccines such as the Mpox vaccine. So vaccination is not seen as a high priority compared to life's other competing interests. Convenience then is when the logistics of getting the vaccine outweigh the perceived benefit for the person, and they see it as difficult to access. It might involve time off work, traveling to a clinic, language barriers, and the person believes that it's just too inconvenient to get the vaccine, not weighing up how inconvenient it might be to actually get the disease, or not realizing how bad it would be to get the disease. And in some recent work I did on the Mpox vaccines, some of the feedback from the community was that the kind of having vaccines just between 9 and 5 Monday to Friday made it very inconvenient or very difficult for them to get the vaccine, and that they should be offered at evenings and weekends. But I know that wasn't at the time, that was when it was more offered in CVCs, but is now being offered in sexual health clinics. But I know it wasn't offered in community pharmacies. And then the last C of the vaccine hesitancy factor is confidence. So perhaps the most complex of the factors and the most relevant following the COVID-19 pandemic is vaccine confidence. So a person may lack confidence that the vaccine is safe, that the vaccine is effective, or that it's necessary. And getting a vaccine does involve a big leap of faith in some ways, and it involves trusting in many different people, institutions, and factors, whether that's subconsciously or consciously. So it actually involves, if you think about it, trust or confidence in policymakers, politicians, and government, in your health system, in your healthcare worker, pharmacist, doctor, or nurse, in scientists and experts, in health professionals in general, in the mainstream media sometimes, and in other media, and actually in yourself. Do I know who to trust? Do I know what sources are reliable? Do I know how to make sense of all the information available to me? And that's becoming more and more difficult for people. So when you think about it this way, it's understandable that some people are vaccine hesitant, and that it is becoming more prevalent now in the age of mass media, the internet, and social media. And navigating the online world and scientific evidence is difficult. Most education systems obviously don't teach critical thinking skills and scientific reasoning. So who is vaccine hesitant? Lots of people from all walks of life. So it's not just one kind of uniform group of people. It's not just conspiracy theorists, as might have been the narrative in the media at one stage. And these are actually a very small minority of vaccine hesitant people. Vaccine hesitancy is a spectrum from downright refusal of all vaccines, so those who are resistant, to just requiring reassurance about some vaccines, so they're more termed hesitant. And this is good news because it means that it may be possible to educate most vaccine hesitant people and to increase vaccine uptake in these groups. It's more difficult in those who are fully resistant, but the hesitant group tend to be more movable. Remember that people who are vaccine hesitant have genuine concerns that, once addressed, may persuade to get themselves or their children vaccinated. And it's natural for people to worry about their own health and about vaccinating themselves or their children. So just to look at the spectrum of vaccine hesitancy here, you can see over on the right, there's those who refuse all with conviction. Over on the left, those who accept all vaccines with confidence and don't question them. And then there's those in the middle, the hesitant group, that actually ranges from those who refuse but are unsure to those who accept but are unsure, and then those in the middle who might take some, delay, and refuse some. As mentioned above, there's a lot of different influences on someone's decision to get a vaccine, even though they mightn't all be conscious. And these include public health and vaccination policies, subjective norms. So what's the normal procedure? What happens in society around you or in the culture you live in? Are most people getting vaccinated or not? What are the attitudes there? Risk perception and trust, communication and media, your health professional's recommendations, and that also might depend on your relationship with your health professional and how you trust them, past experience of both vaccines and of illness, both for yourself and others, the perceived importance of vaccination, what knowledge you have, and also religious and moral convictions. Obviously, data and evidence and science play a part, but in reality, people are influenced by other factors too, such as anecdotal evidence, lived experiences, and emotions. And these can often have more of an influence really on the evidence and the science part on people's decision making. Often we tend to see what we believe rather than believing what we see. And so taking all of this into account, it's how we deliver our messages is just as important as what these messages contain. Vaccine hesitancy is on the increase. It's hard to quantify the rates of vaccine hesitancy, and it's not a routinely collected piece of data, and it's quite complex to collect. But we know it is increasing from population-based surveys and from the proxy measure of falling vaccination rates in some cases. And why is vaccine hesitancy increasing? Well, from a paper I read a few months ago, The Vaccine Hesitant Moment in the New England Journal of Medicine, these are some of the proposed reasons as to why vaccine hesitancy may be increasing. So there's an increased culture, there's a culture of decreased trust in experts these days, the rise of the internet and social media, a rise in belief-based extremism or wider dissemination of belief-based extremism, which is made more possible now by the internet and social media, political polarization, libertarian views, which aren't necessarily in themselves a bad thing, but can increase vaccine hesitancy, alternative healthcare advocacy, and then bad science. And we all know of the example of the MMR vaccine and autism and the paper that was published on that has since been debunked. But that led to obviously years or even a couple of decades of decreased uptake of the MMR vaccine and other vaccines. Also, many new vaccines coming on stream. So, for example, the 4-in-1 going to the 5-in-1, going to the 6-in-1 vaccine, parents can become concerned about overloading their infants, and that's understandable. And the focus on vaccines and their safety during the COVID-19 pandemic probably had good and bad effects. It probably led people to become more aware of vaccines, but might have led other people to question vaccines more with the discourse that was going on at the time. So vaccine uptake in Ireland for all childhood vaccines remains below the WHO 95% target, and some well below. We're talking some of them might be in the 80%, and in different regions can be even lower. MMR vaccination rates have fallen in Ireland over the last few years, quite alarmingly. And in a recent national survey in 2021 of parents' attitudes to vaccines in Ireland, 96% of parents or guardians had intended to have their child fully vaccinated, but in reality, less actually had them vaccinated than those who intended to. 1 in 10 respondents reported that everyday stresses prevented them from getting their child vaccinated. But encouragingly, overall rates of vaccine hesitancy seem to be low. And encouragingly, most parents and patients retain trust in healthcare workers and in official HSE information. So that bodes well for us, giving people information that they do trust healthcare workers. So talking about a little bit more about vaccine hesitancy and the internet and the problems that poses. So even back in 2002, only a few years after Google became publicly available, academics were warning about the effects of the internet on vaccine hesitancy, saying that the anti-vaccination message on the internet is far more unbridled than in other media, and that the internet represents a greater potential for the public to make uninformed decisions about vaccination. However, obviously, the internet can also be a force for good to tackle misinformation and to disseminate accurate scientific information, but this needs to be tackled actively. So just to briefly look at this timeline, it's more just out of interest. It's not trying to draw a direct correlation between the two or anything, but up on the top, you can see over the past 25 years, different developments in the vaccine space, such as the publication of the Wakefield paper connecting the MMR and autism, which was since debunked, and then the bringing on stream of the HPV vaccine, and then two pandemics in the last 15 years, the swine flu H1N1 pandemic, the COVID-19 pandemic. And alongside that, you can just see this kind of explosion of internet and social media sites going alongside that. So it's just interesting to see the timeline, that a lot of changes in the vaccine world, and then at the same time, a lot of increase in social media use to kind of, that just brings an added complexity to those vaccines coming on stream and the discussion around those vaccines. So recent challenges to vaccine confidence have included, now I don't think you can define it as recent really anymore. The MMR thing was 25 years ago, that paper, but it did have a knock-on effect for the next couple of decades, and the effects of bad science. So you can see I have a link further down to a quick read on what was wrong with that paper. Also, the swine flu pandemic H1N1, that vaccine, one of the original vaccines, had a small but significant association with narcolepsy in Northern Europe. It was multifactorial, involving genetic predisposition as well. And this vaccine is no longer used. But I bring it up because just to highlight that sometimes people have actually justifiable concerns. And these should be acknowledged, investigated, and an explanation given rather than dismissed, as that's not, first of all, not a fair thing to do. And it's also an approach that's unsuccessful. Other recent challenges include the HPV vaccine and the well-organised lobby groups that spread misinformation around that, COVID-19 and the emergence of more vaccine skeptics online, and the initial glut of conspiracy theories there. COVID-19 obviously has also been a success for vaccine confidence in some ways, as many people will acknowledge that the vaccines helped us to get our lives back, but this maybe is kind of slipping from people's consciousness now at this stage. The COVID-19 pandemic also highlighted just the importance of human behaviour in tackling infectious diseases. So just to briefly mention the HPV vaccine story in Ireland, and I'm sure you're all quite familiar with it, and it's sort of a success story in terms of reversal of vaccine hesitancy and has been kind of lauded worldwide. So initially, the HPV vaccine in Ireland had an uptake of over 80%. It was as high as 86.9% in 2014-2015. And parental concerns arose then in relation to vaccine safety based on information that then got spread by lobby groups, and misinformation was spread, and it was quite a well-organised group. This resulted in a documentary being aired on national television, and that happened in other countries as well. And confidence in the vaccine was really dented. So uptake of the first dose fell as low as 50% in 2016-2017. 2017. So obviously the NIO, where I worked previously, felt that something had to be done about this. So a steering group of concerned organisations was convened and a strong and coordinated response was initiated. Focus groups with parents were arranged to identify concerns, and all relevant stakeholders in education, parenting, politics were all consulted. An analysis of social media content was conducted and online training materials were reviewed. Training was delivered to healthcare professionals, and this resulted in an increase of, or helped to result in an increase in rates to 61.7% in 2016-2017. So a major reversal from going down to 50%. And obviously, Laura Brennan needs to be mentioned here. Rates increased still further following her selfless and heroic advocacy on HPV vaccination. She was really instrumental in turning the tide of hesitancy as well. And currently, vaccine uptake of the HPV vaccine is 78.4% in the last year for which results are available, 2021-2022 academic year. And so that's obviously a big success story in terms of reversing vaccine hesitancy. So I'm going to briefly talk about this study that I was involved in 2 years ago on COVID-19 vaccine hesitancy, particularly amongst parents of children under the age of 18. Just to mention that when this study was carried out, when the data was collected, it was before the vaccines were available. So it was hypothetical, asking parents what their attitudes or what their actions would be once the vaccines became available. So obviously we know that COVID vaccines are now available in Ireland for all children from 6 months upwards. And to maximise uptake in this group, it's important to understand how to communicate with parents. And to do that, we need an understanding of their backgrounds, their beliefs and their concerns relating to COVID-19 vaccines. This project aimed to determine the levels of COVID-19 vaccine acceptance, hesitancy and resistance amongst parents for their children, to identify the predictors of COVID-19 vaccine hesitancy, so what factors might increase hesitancy and resistance, and to inform communication campaigns to enhance acceptance of the vaccines for children. So the data were taken from the COVID-19 Psychological Research Consortium study. It was the sampling used was a nationally representative quota sample, and it was funded by the HRB and the Irish Research Council. There were 482 participants that had children under the age of 18, so they were the participants included. And the main question we were looking at was, multiple vaccines for COVID-19 have now been developed. Will you give your child a vaccine for COVID-19 when it becomes available? And those who answered yes, or there were very few at the time, it was just when vaccines had become available for very vulnerable people. So there were about 9, I think, who said their child had already been vaccinated. So those were considered vaccine accepting. And those who answered maybe were vaccine hesitant. And those who answered no were vaccine resistant. Sorry. The study methods used, the statistics were all done in SPSS, and cross-tabulation, chi-square tests and logistic regression were used. So of the 482 people who had a child under the age of 18, 52% said they would accept a vaccine when it became available for their child, 30% said maybe, and 18% said they would not accept a vaccine for their child. So the vaccine hesitant group, those who said maybe, were significantly younger, less well educated, less well off, and interestingly or strangely more likely to have had someone close to them sick with COVID-19 than the accepting group. They were also more likely to believe that vaccines were unsafe due to their rapid development, that vaccines can damage fertility, and that scientists and healthcare workers often cover up their mistakes. The resistant group, when compared with the accepting group, were significantly younger as well, but they were more likely to live alone. They were less likely to trust in scientists than the accepting group. And similar to the hesitant group, they were also more likely to believe that the vaccines were not safe due to their rapid development and that they could damage fertility. Some of the most interesting findings, I think, from this study were actually the non-significant findings, which is unusual in that at the time, the discourse in the media was that vaccine hesitant people were often conspiracy theorists or believed in niche conspiracy theories, but none of these came up as significant in the findings. So the vaccine giving you COVID-19, the vaccine altering your DNA, or the vaccine containing a microchip, none of those were actually significantly related to vaccine hesitancy or resistance. So the study limitations were that it wasn't a random sample, but it was representative. One of the major limitations, I think, was that it wasn't broken down by age subgroup. So you might have quite a difference in who might accept a vaccine for their 17-year-old, say, compared to their 4-year-old. And that there was obviously some potential for bias, as with all these types of studies. So what are the implications then of this study? And mostly the implications are around messaging to do with vaccines, or around how we talk to people about vaccines. And that's around targeting of the messaging, the content of the messaging, and delivery. So younger, less well off and less well educated parents are a target group for communications to increase COVID-19 vaccine uptake in children. The messaging should be clear, concise, and jargon-free, and should focus on the safety profile of the vaccines, outlining how they were developed, rather than on non-scientific conspiracy theories. And the messages how the messages are delivered and by whom may need to differ for the vaccine hesitant and resistant groups, with the resistant groups, so those who said definitely no to the vaccine, less likely to trust in scientists, and therefore they may be better targeted. So, at the time there were sort of high profile or celebrity scientists, but actually they may have some effect sometimes on maybe the hesitant group, but probably less likely on the resistant group who don't trust scientists anyway. They might be better targeted by trusted peers, community leaders, social media, maybe online parenting groups, influencers, and celebrities who might be able to more influence people. So just a couple more slides on what we can do as healthcare workers to influence people, or to talk to people who are vaccine hesitant. So people trust healthcare workers. That's a good thing. Vaccine decisions, as we said, are based on many factors, and very much in there is the emotional factors. The way we talk to patients matters, and the messages we deliver matter. But how you say it matters as much as what you say. And clear, concise, easy to understand information is important, with no jargon. Address genuine concerns, and consider using some motivational interviewing techniques. So motivational interviewing is recommended by the WHO to address vaccine hesitancy. It's also used for various other health issues. I understand that you all may have access to HSE Land, and there is actually another module up on HSE Land called Talking to People About Vaccination. I'll add that to the slides at the end to circulate. But that goes into a little bit more detail on motivational interviewing and how to do that. But just briefly on motivational interviewing, the techniques can be used for short interventions. It doesn't always have to be a long conversation. The main points of motivational interviewing are that you ask open-ended questions, you reflect information back to the person, what they have said and what you think they mean. You respond to any concerns raised, but don't get into a fight. And you affirm strengths and validate concerns. So you might say, it is great you are thinking about vaccines, to affirm the strength, and validate their worries by saying it's natural to worry about doing the right thing for your health, or doing the right thing for yourself or your child. You ask, provide, and verify the information. So ask what they understand, provide information, and verify what their understanding is now after having had the conversation, and has it changed. And you summarize and describe the next action. So if they've decided that they are going to take the vaccine, reflect that back to them, or decided that they might go away with some information that you give them about the vaccine. So you just describe that next action. Other things that you can do and that have been proven to help are remind people about vaccination, make appointment times convenient, make the location as accessible to the person as you can, and to take opportunities to recommend vaccines. So for example, say if someone's going to their GP for a pregnancy visit, that they might remind them about their vaccines there. If someone's in the pharmacy asking for flu and cold medication, that you might remind them, have you thought about booking in your flu and your COVID vaccines? Just something like that, taking every little opportunity, so similar to the making every contact count HSE approach. So I've just listed here, and they'll be circulated afterwards, a few quick reads. I have my reference slide after this, but there's just 3 quick reads that I've mentioned here. They all would take a maximum about 10 minutes to read, that I just thought were really interesting and really informative. So the vaccine hesitant moment that I mentioned before, there's a short paper on the rapid response to HPV vaccination crisis in Ireland. And then just there's a paper then, a very brief paper on what was actually wrong, because I was trying to educate myself about this, what was actually wrong with the Wakefield paper on the connection between the MMR and autism, considering it had such far-reaching effects. And it's just very interesting to look at actually how badly conducted that research was, and to look at research that's been done since. So that's a very brief paper on that and what was wrong with that paper. My references are listed there. And thank you very much for listening, and good luck in your work helping us to promote vaccines. And I'm happy to take questions. So I'm just going to stop sharing my screen there now.
That was great, Ruth. Thanks very, very much. As I said, just to remind people, if they have questions, we have our chat box there, and if they put it into the chat box, I'll have a quick read, collate, and put any questions to Ruth. It was really interesting overall, Ruth. I found it fascinating. And I suppose one thing was, as you said, the advance of hesitancy in general terms with the advance of social media, that it just is such a powerful connection. But I suppose it's great to see that people like the HSE and that are going, well, okay, we can turn that on its head and we can use it to deliver the messages properly as well. Just a quick question I had was, you did your Irish research, and I think the figure there was you had a hesitant group of was it 18 or 30% who said, yeah, we're not sure, we might. When you kind of put in your intervention, maybe to say, well, here's all the information and your motivational questioning and that, did you see in terms of vaccine uptake, did that have a positive effect?
Well, so yeah, that study looked at, it wasn't necessarily an intervention study, but it looked at it was a survey. So what was the expected uptake?
Oh, yes, sorry.
And I think it was 50-something% said that they would accept the vaccine for their child.
Oh, yeah.
And actually that's not how it's played out. The vaccine uptake rates have played out quite differently in real life, but it is quite different across the age groups. So in terms of the sort of a first course of COVID vaccine in children over the age of 12, it sort of ranges from about 60 to 80% over that age range from 12 to 18. But then when you look at sort of 5 to 12-year-olds, it's down around 20%, and under 4s, I think is down around 1%. So it's very, very low. So as you can see, it's quite different across the age groups, but the uptake, I'd say, was even less than expected. So it's quite different what people said that they were planning to do, but then as I said, the research wasn't divided by subgroup across the age.
Yeah.
That was a limitation there. And it's also obviously in 2021 when the research conducted, people were probably a lot more concerned about COVID. So there's a lot of factors there, but it's interesting to see that the uptake in those groups has really been quite low.
Yeah, and I think it's probably something you highlighted in one of your slides. And I definitely get that the number of vaccines and the vaccine schedules have become more and more complex. And even with COVID vaccines changing every year, it just brings new information, gone to a quadrivalent flu vaccine, that type of thing. So it can, it's just a kind of a glut of information that people, as you said, back to your factors at the start, they just maybe just walk away from it because there's almost too much information to process.
Yeah, and I think that's probably a term I didn't even use in the presentation, but people are talking a lot about vaccine fatigue now. It's not even hesitancy, it's the people are just tired. And as you said, there's so much information, there's so many vaccines, and people are just tired of it. So
yeah. Two interesting questions. The first one is, and I hope I pronounced the name correctly, Madhup. She said, she queried, are we seeing vaccine hesitancy amongst healthcare workers? Is that something that we're seeing?
Yeah, we're certainly seeing a lot of vaccine hesitancy amongst healthcare workers. I'm sorry, I don't have the figures to hand. But that's been a major concern of the NIO, and there's a lot of work being done on it at the moment by the National Immunisation Office, just in terms of trying to encourage healthcare workers, at least within the HSE anyway, to get particularly their COVID and flu vaccines. But yeah, sorry, I should have the figures there handy, but definitely the vaccine hesitancy rates have really increased amongst healthcare workers. And the intentions to get particularly the COVID vaccine have really dropped, the COVID booster vaccine. So there's a lot of work being done to try and push that at the moment.
Yeah, but I suppose then, as you said, fatigue and there's a lot of factors there, but yeah, you can see it. I have another question here, and I'm just going to read out. can I ask about justified vaccine hesitancy if it exists? And I suppose it's around if they have had previous COVID infection, should they get the vaccine?
I think so first of all, just to say about justified vaccine hesitancy, yeah, I think that's actually a good word to put on some of it, because I think I'm not saying it's justified that they shouldn't get the vaccine, but as I've said, there's a lot of people with concerns about vaccines, and they actually have valid reasons for being concerned, or they're thinking about it, and they've concerns about the safety profile or the rapid development, and we have to be understanding that there are reasonable reasons sometimes to be concerned, but that we know as healthcare workers and as scientists that the evidence is that they are safe, and we have to communicate that appropriately to people. In terms of people who might have had COVID previously and had concerns about getting the vaccine, as far as I'm aware, there's no evidence to suggest that there'd be any contraindication to getting the vaccine for those people. I know that there had been reports that people can sometimes have more of a reaction to the vaccine. That was maybe back earlier on in the pandemic, that when you got one particular brand of vaccine, if you'd had COVID before, you might have more of a reaction to it, anecdotally, but there's no evidence to suggest that the evidence at all point that people should still be vaccinated. And that hybrid immunity, so being both vaccinated and actually having had COVID before, is actually better immunity than just one type of immunity. So
okay,
all the more reason.
This I suppose it follows on slightly from that, and I suppose it's trying to do with the side effect thing that somebody's queried. They're having a discussion to say the patient is due in for their COVID booster and come along, but they said, oh, the last time I got my booster, I got heart palpitations. They've been completely compliant with getting any jabs that are recommended for them, but they had palpitations last year, and they're just, whoa, not so sure this year.
Yeah, that's a difficult one, because I know you're in a difficult position when you're at the kind of your frontline worker and being asked those questions. And I would be slow to be providing reassurance to someone when you don't know their medical history. I'd be telling them they need to go and check with their GP if they've had heart palpitations. Was that vaccine related? Was there something else going on? So they definitely need to be checking with their GP before proceeding with the vaccine, I think, in that kind of circumstance.
Yeah, exactly. Yeah, I suppose you'd have to probably do a lot more teasing out to get a full picture, and I suppose work on the information that you gather from there. There was sorry, that's just the questions that have come in so far. I'm just double checking that I don't have any more. There was just one thing on your presentation which is slipped my mind. Sorry, I was busy manning the things there. I'm just having a quick look. In terms of the targeting of the messaging, I suppose the brief interventions that, and again, I'm thinking as pharmacists, it's something probably most people would have seen initially, certainly in smoking, stopping smoking, and just as I said,
yeah.
Brief interventions. Are they planning to do more work in that area as part of this, I suppose, increase uptake, vaccine uptake, and manage vaccine hesitancy? Is there any thoughts on that?
In terms of how the messages are targeted, or
yeah, and actually that was the other thing. Sorry, we talked about age groups where certain age groups do better than others, and I'm thinking of children. Would there be plans afoot to try and manage that?
In terms of the childhood COVID vaccines, as far as I'm aware, there's not plans to put a big push in terms of a media campaign for the childhood COVID vaccines. At the moment, the HSE wording is that they're available for different age groups, and they're recommended then for certain subsets who have certain medical conditions. In terms of trying to kind of increase vaccine uptake, there's certainly work going on about, is there a way of providing more training on things like motivational interviewing to different types of healthcare workers, possibly midwives, possibly nurses, but that's all none of those are completely concrete plans, but that's all I know about at the moment. I'm not working in the National Immunisation Office now at the moment, so I'm not sure exactly what their programs are. I know the major push at the moment is on, as someone mentioned previously, the healthcare workers and communications around that. So that will be the major push in terms of communications. Yeah.
Okay, perfect. And we're well ahead of schedule, which is great for everybody concerned. As I said, I haven't seen any more questions come in, so I don't know if we have any more questions. So I'm just thinking, I'm not sure we've done anything else or I have anything else. I don't know if you've any final comments or queries to motivate our pharmacists out there who are launching their flu and COVID jabs.
That's a big ask. You're well able. Or fireworks or something, but just go forth and please promote vaccines. And I know you all do already, but thanks for all the great work, because we obviously are sitting in offices and thinking of it from that point of view. But I know from my clinical experience in previous jobs that when you're actually talking to people one-on-one and you're on the front line as a healthcare worker, it can be a lot more difficult in practice than in theory, and you can have quite difficult conversations. So thank you for doing all that, and hope you wish you success in continuing that.
And actually just somebody has come in and they're saying, sorry, it's slightly after, but it's back again, why there's so much hesitancy in healthcare workers, or what is there? Do we know why there is vaccine hesitancy in healthcare workers who in theory should know all about these things?
I'm going to see if I can pull out, I think there was some research done on this recently and I don't have it in my presentation, so I'll try and see if I can pull it out to disseminate, if that's okay, Grace and Ceannt, with my slides or with the presentation. I think mostly the feeling is that it's this vaccine fatigue. There's nothing too specific coming out, that people that they're just tired of it. And also I think there could be some concerns about getting the two vaccines. There's a push to get COVID and flu vaccines together, and possibly people are concerned about that or about the side effects of that. But I haven't done any research on it myself, so I'll try and pull out. I think there was something done on it recently on attitudes amongst healthcare workers, so I'll just check with my colleagues and see if they're happy for me to share that.
Perfect, that's great. Yes, and I said, yeah, I certainly see where I am, there's big campaigns by our community pharmacists, social media ads, etc. So yeah, I'm going to take advantage and speak for everybody to say they are definitely pushing it. Those who are doing the services are pushing it. So hope we have a good season on the vaccines front. Okay, everybody. I think I have one or two more slides just to share, which Grace is going to bring up. Again, we're doing these webinars, and they're really very much based on what people tell us. So there's a quick survey there asking for your feedback on this topic and suggestions for other topics, as well as some general questions. As ever, we have CPD, and I suppose we're just bringing up our CPD slide to say this might be something that you reflect on, and it might allow you, first of all, to consider what impact you'll have on your practice. I thought there was some really useful for me back to your brief interventions and thinking about who to message and how to message, and even just relating the message back and that. So some really practical information provided by Ruth to us that people might want to put into practice and then go on to complete their CPD cycle. So we're back in 2 weeks, and it's with Dr. Frank Moriarty, who is really a leader in polypharmacy and getting pharmacists involved in de-prescribing and that whole side of things. So we're here, it's myself again there in 2 weeks, Wednesday the 25th, I believe. And he's going to talk to us about, and I've checked, it's called I don't know if it's starting with the end in mind or starting with the end mind, polypharmacy and e-prescribing in research and practice. And I know he's a leading light, and I think he's gotten some funding for some really big projects. So it'll be hopefully a very interesting talk on what we're doing, where we're going, and how we can maybe all get involved. So again, thanks to Ruth and thanks to Grace for her IT support. And we'll let everybody on to their evening. And I don't know if Grace has anything else to say, but I think that's it from me.
No, that's all good. Yeah. Thank you.
Okay, everybody. Thanks very much, and have a lovely evening.